So it's truly an honor to be here and very humbled by this opportunity. I stuck with my assigned topic, so at least we'll talk about that. Here are my disclosures. I work in the most beautiful place on earth, so here you go, but we are in a gorgeous place today, so thank you again to be here. I focus on these three items to talk about the SVS, STS reporting standards, and then we'll talk about the other guidelines. And I appreciate the previous speakers having laid the foundation for what I'm going to talk about. And I also want to say that type B dissection, I think, is the stepchild in this aortic dissection world. It's less represented, and I still think there's far more opportunity for data to improve the survival for people affected by that. I am going to focus on the definitions, classifications, the multidisciplinary aortic teams. You've heard extensively about that today, so that will just be a touch upon. And then I'll talk briefly about shared decision making. I am going to touch on genetic testing because it is a topic I'm quite passionate about, and I'm grateful that Dr. Diana Milowitz is here, and she'll talk much more extensively about that, and then we'll talk about surgery and then challenges. Just briefly, I'll touch to say that SVS is currently working on 2 guideline documents, and that goes back to that discussion about each organization's working on guidelines, but there's certainly those 2 documents specifically on genetic aortopathy and arteriopathy, and one on type B aortic dissections. It's nice to go historically, at least for the junior folks in the room. The Bakey versus Stanford classifications, I think those were sentinel works in terms of trying to understand or codify these dissections. And basically, the DeBakey classification was simply, can you approach this via median sternotomy versus thoracotomy, whereas the type A and type B focused on the pathophysiology and the ascending aortic involvement that way. Neither one at that time talked about aortic arch involvement. You've heard a little bit of that discussion earlier today. So that leads us to the SVS-STS classification. I think this was quite relevant, and it's been out now for a couple of years, and many of you in this room were involved in this discussion. But basically to revisit this classification into basically based on zones of the aorta that are involved, whether it's a zone 0 or not a zone 0, and that's a very simplistic way of saying it, but the bottom line is when you think of type B aortic dissection specifically, we're talking about any dissection with an entry tear that is not in zone 0. And then, the classification goes on to talk about the proximal extent and the distal extent. I remember when this first came out, we're like, oh my God, who's going to remember all this stuff? But surprisingly, there are many physicians in the emergency rooms who now call and say, I have a type B zone 3 to zone 9, and they're able to communicate quite well. So it's become part of our lingo, and it just shows you that repetition is mother of retention, and I think we're doing a good job with that. The other thing that was relevant for this is that it talked about the chronicity, which you saw the slide earlier today, and I'll touch on that again, and then high-risk dissections as well. So again, we looked at I summarized the guidelines specifically, again, looking for type B aortic dissections. And just fun fact, I don't know if people know, how many times was type B dissection mentioned in this document? Any ideas? All right, 61 times. So. Okay, so the chronicity classification is relevant, the hyperacute versus acute and subacute and chronic phase. That is slightly different than prior documents where the chronic was considered greater than 30 days, and now we're saying chronic is greater than 90 days. So that is one of the changes that has happened. And then really the document focuses on the idea, is it a complicated or is it an uncomplicated dissection? This can be a whole session unto itself. Is there such a thing as an uncomplicated type B versus complicated type B? But for simplicity, what we are saying is a complicated type B has organ malperfusion or has rupture. So it's badness that is manifesting in real time early on versus quote unquote uncomplicated. And so based on that, the guidelines say that medical management is still the first line of therapy. This has been around since the 50s, since they discovered that turkeys have aortic dissections and that you can treat them. That hasn't changed, and you heard the first speaker talked about this. And then also it highlights that if they are experiencing during pregnancy, still medical management is first-line therapy in the setting of an uncomplicated. And I appreciate that the document highlighted pregnancy because that is a topic that tends to be ignored, but that was centered in the document as well. So intensive medical therapy is first guideline. There's a lot of discussion about the complications, and I said simplistically, rupture and malperfusion is a complication that has severe consequences in terms of survival in the acute and hyperacute and acute phase. And the document highlights the type of malperfusion, whether it's static or dynamic, that is happening at that time. Aortic rupture, obviously, is pretty easy. That's a problem. It does talk about extension of dissection and aortic enlargement, but there's not clear guidelines around that, but there is discussion. It's mentioned in the document itself. And then intractable pain and uncontrolled hypertension, you saw the data today showing how these are correlated to worse outcomes, and I'll show that in another slide. The bottom line is if you have a complication that is clear and present danger, central aortic repair is the mainstay, and that is with a TEVAR or the endovascular management, where we've shown now that is a better option compared to open repair. And again, that's not new data in the sense that if you look back at the data in the 50s, when people compared medical management versus open repair, they've showed that medical management was superior, and now we have TEVARs, so now that has changed. It's been a game changer for that population itself. And obviously, this is a sentence that I just copied directly, talks about how rupture, when you treat it with a TEVAR, you're not burning any bridges, you are still setting yourself up for subsequent repairs. So that's just important to keep in mind. And then in pregnancy, again, 20% of the type B dissections that occur in pregnancy are complicated, and then therefore endovascular repair is still preferred over an open repair in that circumstance. But if you can get through the pregnancy with medical management, that would be ideal, and then deal with the dissection. But 20% are complicated. You saw this picture earlier about the malperfusion. I just pulled it out specifically for type B aortic dissection. And the end of the bottom line is you are addressing the false lumen and the TEVAR in the setting of rupture. And if you have malperfusion, endovascular fenestration, what's missing on here are the slinkies that we have now by Cook that can reline the entire aorta. That is also evolving in terms of getting more data to say, does that work? Should we routinely put those in? It's not in the guidelines, but it is something we talk about, at least in the vascular surgery discussions. And then the TEVAR, and how far should you extend the TEVAR when you do these operations? And should you do adjunctive branch vessel stenting, or should you do an extra anatomic bypass, depending on whether or not you have resolution of the malperfusion with the TEVAR? Okay, well, what about uncomplicated who have high-risk anatomic features? I have Firas's picture here because this is a favorite topic of Firas Musa, and he can go on for hours on this topic. But these features, anatomic and clinical, have been described as being associated with worse outcomes. You've heard about the refractory hypertension and pain already. You've seen the data for that. But then also these high-risk imaging findings that suggest that this person perhaps has an unstable aorta and is at high risk for worse complications. And that in that sense, and you can see it in the other guidelines as well, to say that it is reasonable to consider delaying treatment for these patients, treating them, but delaying treatment to get them at least out of the hyperacute phase and to treat those patient population. I like the take-home message. This was number 9 that talked about that increasing role for TEVAR in management of uncomplicated type B. There's a whole session on this happening today, and this is still a hot topic. But basically, you know, should we treat those folks routinely with TEVAR because we know that they are at risk for complications in the long run? And therefore, is there a window of opportunity to induce favorable aortic remodeling if you were to treat them earlier rather than waiting? But we know that not everybody proceeds, you know, or progresses over time, but it's trying to balance, you know, can I predict who's that person's going to be, and can I give them the best repair early on? And so you see, again, in both guidelines, there's a discussion about this prophylactic TEVAR and uncomplicated type B, and as I mentioned, there's a whole session coming up on this a little bit later. Well, what about long-term management? You can see that, again, when you put a TEVAR in those patients, you're still dealing with an issue of a potential patent false lumen, and you've heard the discussion about the status of the false lumen and how that impacts where you are with the remodeling of the aorta over time, and additionally, there are failure mechanisms for these devices, early and late endo leaks. The other topic that comes up frequently now is what to do with a thoracoabdominal aortic aneurysm in the context of a chronic dissection, and should we treat them with complex endovascular repair as opposed to open repairs, and what are the long-term outcomes? And right now it seems, again, open surgery is reserved for cases where TEVAR is not feasible or fails. That is a statement now that I'm seeing in the documents versus just saying let's just proceed to open surgery in those circumstances. But I do like in the WATS guidelines. It highlights modes of failure, and I think this is really important as we push ourselves in terms of developing technology to improve the repairs in these patients. Shout out for the multidisciplinary aortic team. You've heard a long discussion about this, as well as regionalization of care, and I think that was really great to have that in the document. And the other thing that I loved was the shared decision-making. I've done a lot of work engaging with patients and communities, and I think this is so important, particularly when there's positive data on how to proceed, and we still have to personalize that therapy to the person sitting in front of you in a chair wondering. The genetic testing, this was great, and I can tell you that from an insurance perspective, all I have to do is I print this and I send it to the insurance company, say, hey, they need testing. So this is actually, having this in the guidelines was really relevant, and Diana Milos will talk about this more in detail, but I think having it in the guideline was super important to make sure that we get this resource to patients. And then Marfan syndrome specifically, the document talked about Marfan syndrome, Loeys Dietz, and vascular EDS. Vascular EDS, basically the highlight is it said there's positive data, so there's really not a whole lot to go about. Marfan syndrome, I think, had the most robust data in the document and highlighted that 10% of people with Marfan syndrome have type B aortic dissection, and the risk factors were highlighted, which is potentially prior elective repair prior to that, previous dissection elsewhere, or pregnancy, and in fact, 20 to 40% of pregnancy-related dissections occur in people who have Marfan syndrome, so that's a relevant piece of information. And TVAR, as it comes to how it's used in this population, there's a debate on this tomorrow, but TVAR is an important consideration in this population if they are presenting with rupture or malperfusion. You need to get them out of hot water. So it is a reasonable approach in that sense. But open surgical repair over TVAR is a more durable option in the guidelines, and is mentioned in the guidelines when you're performing this in an elective setting. The other thing that the guidelines have done very nicely is that they highlighted cut points specifically by genotype, so a gene-specific approach for Marfan and Loeys Dietz that was in there. So I have 3 slides on challenges and gaps, and this is my wish list. And it's funny enough, I was thinking also that a lot of this hasn't changed in the last 15 years in terms of my wish list of how I want to see this. But the big hot topic right now is the role of TVAR in complicated type B, and you'll hear more about that. But the early risk stratification and late complication prediction still remains the panacea, if you will. Can we figure out who's at low surgical risk, who will have excellent aortic remodeling, and can we forecast to say that you are the person who's going to benefit from this repair rather than you're the person who's going to be harmed by this repair? And then also understanding device failures and poor aortic remodeling post-type B aortic dissection, TVARs, and then the high rate of reinterventions. We've seen this now. We know that there's high rate for reinterventions. And then the value of these clinical and anatomic high-risk features, again, that's a topic, that's a hot topic. How can we incorporate these in our predictive modeling? And then what is the optimal surveillance imaging frequency? Again, how do you balance that versus patients' anxieties on an annual basis? The other thing is type B dissection remains unpredictable, and Loeys Dietz and Marfan syndrome, we know they're at risk, but it's unpredictable. Frequently, it's not preceded by aneurysmal degeneration, so we do see that. We just can't predict it. Vascular EDS, there's plenty of room in that arena. And then even optimal management in people with smooth muscle cell gene variants, I mean, that population phenotypically looks different and can behave clinically in a different manner than the other populations. So not all quote-unquote connective tissue disorders are the same. There's definitely variation by gene affected. Pregnant individuals and children still, again, remain an area that we don't know a lot about as well. So we have to think about personalized treatments that are based on their genetics, age, and functional status. When is open repair preferred over complex aortic repair? Complex aortic repair is very attractive in principle because it's quote-unquote minimally invasive. However, it carries a significant burden of reinterventions and rehospitalizations in some people, and so therefore, is it better to have one big hit up front that is more durable, or should you take pieces along the way and continue coming back? And then there's gap in recommendations for managing chronic pain, psychological impact, and rehabilitation. I think I'd love to see this in the future and when we write these guidelines, how to address that. And what are the optimal shared decision-making tools? And this is just a thing to remind everybody, even though we're recommending genetic testing, there is a significant gap in the United States, maybe in Europe too, but in the United States you can see there are deserts where there are no access to anybody with genetic expertise. And we are not training enough geneticists. So for the geneticists in the room, please train the next generation. We need more geneticists. A third of the clinical genetic residency positions were unfilled at the time of this paper when it was published. That is a problem. We need to get medical students interested in genetics. And then obviously the more testing you do, the more you're going to see VUSs, and how do we interpret those. So I think that is going to be our challenge over the next decade or so. So I appreciate your time and attention. Thank you so much for the opportunity.